Welcome to the EAU podcast.
Welcome, everyone. So my name is Neha Sihra. I'm an associate editor of the UROLUTS educational platform. I'm a consultant urologist from London. And here today I have Dr. Yasmin Heiniger from Zurich. And we've invited her to interview her on the work that she's published on robotic-assisted simple prostatectomy. So we found the abstract in the AUA program, and we found this very exciting titled Multi-Institutional Outcomes of Robot-Assisted Simple Prostatectomy, a retrospective study by the ERUS Scientific Reconstructive Working Group. And we are planning to ask her some questions today to understand a little bit more about the data. So tell us more about yourself and the ERUS Scientific Reconstructive Working Group that you're a part of.
So I'm Yasmin Heiniger. I'm a robotic surgeon based in Zurich, and I am part of this ERUS Reconstructive Scientific Working Group, which basically brings together some robotic active surgeons to allow data gathering, as we can show you today with this data that I'm presenting about robotic-assisted simple prostatectomy. And the interesting part of this group is that we can also gather patient data on rare stuff like, let's say, urethral strictures or things that are not treated very often in only one clinic. And this group allows a lot of multi-institutional data gathering, which is very interesting.
Amazing. No, definitely an important area for us to focus on because, as you say, there's not so much in the literature, and this is something that is now growing and evolving. The
Absolutely.
use of surgery for benign procedures. So robot-assisted simple prostatectomy is a very interesting one because we're currently sort of living in a world where we have so many different options for the management of benign prostatic enlargement, all the mists, all the enucleation procedures. We've still got our TURP, and then now we've got this more and more sort of evidence around robot-assisted simple prostatectomy, which has been around for a while, but it hasn't been adopted so widely. So for you to have published on such a large series is very sort of interesting to read. So having read through the abstract, I can see that there are, and you already know that there are various different approaches surgically that can be performed for simple prostatectomy. So do you want to just tell me a little bit more about that and the sort of data that was included in this series?
Absolutely. So in addition to the data gathering and the case series that I'm presenting today, I am performing a systematic review, which we are publishing now, to identify the different surgical techniques available for robot-assisted simple prostatectomy, and in general, to divide them into 4 main steps. So we found a large heterogeneity also in the terminology, which is also difficult to compare the different operational possibilities. So after this systematic review, I can show you 4 main steps of the robot-assisted simple prostatectomy. So principally, we have first the surgical approach, which can be either transperitoneal or extraperitoneal. Additionally, with single port systems, it can be direct vesically. Second, the access to the adenoma. This is either transvesical, conceptually similar to the Freyer technique, or transcapsular, which corresponds to the Millen approach. Third, we can talk about the enucleation technique, which can be standard enucleation in the adenoma plane or urethra sparing, where you spare the whole urethral mucosa. And fourth, the type of the urethral reconstruction. They run from no reconstruction to partial or complete reconstruction with a full anastomosis, according to the Van Veldhoven technique. That's basically it. So the 4 main steps and the standardized terminology is one of the main goals in this systematic review. And in the data that I'm showing today, or which I'm talking about, these 4 main steps and the different techniques of each step is also important to understand.
Yeah, no, it would be really useful to understand that because people do so many different things, don't they? As you say, all the eponymous names, Freyer, Millen's,
Yes.
in the prostatic fossa, partial closure, complete closure. And what is the best thing to do? Or are they all fine and safe and it doesn't really matter what you do? But from the data that you've looked at here, which one would you say has had the most favorable outcomes, or are we unable to sort of conclude that?
So principally, all of the different techniques have similar comparable results, but in terms of advantages, for the surgical approach, we can say that the extraperitoneal approach is mainly associated with the lower risk of intra-abdominal injuries. For the access to the adenoma, the second main step, the transcapsular approach, which is aligned to the milin, allows a complete preservation of the bladder neck and a complete extravesical surgery, which also many experts of the field, they say that this is the game changer because you don't hit any injury to the bladder neck. And then for the reconstruction technique, a full reconstruction of the lower urinary tract can further offer functional benefits and lower complication rates because there's a complete exclusion of the prostatic fossa. Furthermore, very good outcomes are particularly seen with urethra-sparing enucleation, which is also something that is coming up, where the urethral mucosa, the bladder neck, and the verumontanum are completely preserved. In addition, single port surgery also shows very promising results due to minimal invasive nature.
But you mentioned earlier that the sort of advantages of a extraperitoneal versus intraperitoneal approach, and one of them being reduction in risk of any sort of intra-abdominal injury. What sort of complications were reported in this series?
In this series, we have no complications which was due to the intraperitoneal approach, which was higher than Clavia and Dindo 3. So we don't have any injuries of the bowel. I think robotic surgeons know how to handle it so that it doesn't happen, which also would be a catastrophe in a simple prostatectomy surgery. But we can see that the patients had lower complications with obstipation, and they can go home earlier because of reduction of pain.
One of the things that I've sort of seen anecdotally, and we know with most prostate surgeries, the risk of UTIs post-operatively. What was the sort of rate of UTIs in this series, and what did you do to try and sort of mitigate that risk perioperatively?
So we have two common minor complications, which are post-operative hematuria. It occurred in 4%. And secondly, the infections, as you are saying, which occurred in 3.6% of all patients. These are also the complications that are the most bothersome for the patient and can be significantly influenced by the surgical technique, in my opinion. In this retrospective data, we particularly observed a reduced overall complication rate in the urethra-sparing enucleation and in the cases with full urethral reconstruction. This suggests that preservation or even complete reconstruction of the urinary tract may lead to better functional outcome, particularly in the short-term follow-up. And experts of the field believe that this might be because of the clothing of the prostatic fossa through full reconstruction, and this contributes to a reduction of post-operative infections.
Amazing, that makes sense. And sort of on the subject of functional outcomes, if I'm not mistaken, in this series, patients were followed up at sort of 6 weeks and then 1 year. Is that
Exactly.
Right? So what were the sort of long-term functional outcomes in terms of continence and sexual function?
So continence data were not collected in a fully systematic way. As we all know, standardized questionnaires were often not used across the participating institution. However, the IPSS score was recorded relatively consistently, and it also includes questions related to continence, particularly urge incontinence. For example, the ability to delay urination is shown in the IPS score. The IPS data showed over a 12-month follow-up time a strong and a sustained decrease to a very low level of below 10 points, which indicates also good continence outcomes. Furthermore, the quality of life dropped to 1 point only, which in my opinion also confirms a bit that the patients weren't unhappy. And in my opinion, if they're incontinent, quality of life score wouldn't be 1. An additional important finding is that we also have a very low bladder neck stricture rate, which was documented only in 0.3% of all the patients. And this is certainly a major advantage compared to the reported data in the literature after laser enucleation of the prostate.
It may be difficult to answer this question because this is obviously a multi-center series across both Europe and the United States. So the sort of perioperative management might differ between every unit. But in general, what is the post-operative management for these patients? Meaning sort of how long are catheters left in for? Do we do cystograms before we remove them?
It's a very challenging question, especially also because we all work in different healthcare systems. As we all know, the participating centers across Europe and the US don't have the same post-operative standards. But I can say that after a transvesical access, the catheter is typically left in place a bit longer, in a median of 4 days. In contrast, after a full reconstruction, the catheter can mostly be removed on the first post-operative day in cases where the patients already have a suprapubic catheter or where a suprapubic catheter is placed intraoperatively. So I think this is one of the main advantages of a full reconstruction, that you don't need bladder irrigation and you can take away the transurethral catheter earlier. A cystogram, however, is not routinely performed across all techniques.
Okay, that's really useful to know. What was the sort of average size of the prostates or the range of prostate volume that was included in this series?
The range was 110 to 118 milliliters, and the median prostate volume was 140 milliliters.
It's just, again, there are going to be a lot of people that are more enthusiastic about other enucleation procedures, such as some of the laser ones, HOLEP, for example, and then just trying to sort of justify the role of robotic simple prostatectomy in our armory. It sometimes takes a little bit of convincing. I mean, you've done a pretty good job so far to try and sell the many advantages of this procedure. Just a couple of things that may not have been looked at in this data set. So cost. Do we know anything about the sort of cost effectiveness of this procedure compared to some of the other techniques that we use?
I think for now, this is obviously the less cost-effective procedure. One of the points is also that we usually compare operative time and complication rates without regarding the prostate volume. And I think the prostate size appeared to be one of the key factors in decision-making. So in this retrospective data, the median prostate volume was 140 milliliters only. But the simple prostatectomy is generally the size-independent approach. Prior to this data gathering, I performed a data registry with a multi-center questionnaire, and it was also presented last year at the conferences. And then among the participating centers, only one center performed exclusively robot-assisted simple prostatectomy. Most of the centers, however, offered both RASP and anatomic enucleation of the prostate. And the prostate size was asked in this questionnaire where the limits are. So while endoscopic enucleation techniques are generally be offered to a prostate size of maximum 200 milliliters, RASP was size independent and was running up to 400 milliliters. In our clinic, the decision between anatomic enucleation and the robot-assisted simple prostatectomy is also size-dependent. So generally, we offer prostate volumes of 100 milliliters or below. We offer laser enucleation, while bigger glands are treated with robot-assisted simple prostatectomy. In addition, when concomitant surgery is required, such as hernia repair or bladder diverticulum resection or big bladder stones, the robotic approach is often preferred.
And then just sort of final question. So you've sort of spoken about some of the procedures being size dependent or size independent. So let's talk about one of those sort of gray area ones. So you've got a 180 cc prostate. So patient would be eligible for both procedures, laser enucleation or a RASP. In terms of sort of counseling, how do we discuss this? And what would make us decide one procedure over the other? Obviously, ultimately, it's patient decision as well, but we can influence that to an extent by informing them. So how do we discuss that?
Principally, I think, first of all, it's also surgeon's ability to perform one or the other procedure, and the knowledge of a center which approach is discussed with the patient. I think 180 milliliters is relatively large gland, and not everyone is fully sure to perform anatomic enucleation in a large gland like this. I think the knowledge is growing and growing, and today this is a standard possibility, but I think the surgical knowledge is one of the key factors in the decision making. Furthermore, I think that especially patients that have a lot of urgency and frequency, who are maybe even stress incontinent, these are probably the patients that I would prefer a robot-assisted simple prostatectomy, because you can perform a full reconstruction and a full decompression without a left open prostatic fossa. And also patients that are searching an approach with antegrade ejaculation. In these patients, the urethra-sparing approach is very beautiful, and they have very good long-term results on sexual outcome.
I mean, we need an RCT, don't we? It's amazing that there actually hasn't been anything.
Absolutely, yeah.
So something that perhaps we can collaborate on together.
That will be very important, I guess.
For sure. That will help answer a lot of our questions.
Absolutely.
Great. Thank you. I mean, is there anything else you wanted to sort of add or mention that I've not touched on?
No, I think you just said what is necessary. I think we need to go on in prospective designs and also in RCTs to really answer these questions, and also to really have the long-term results, especially bladder neck stricture isn't something that happens in the first weeks. And I think these are the main take-home messages for the future if we look ahead to have these data ready in the discussion.
Thank you, Dr. Heiniger. Lovely to speak with you.
Very nice. Thank you very much.
Thank you for listening to this episode of EAU Podcasts. For more updates on functional urology, please visit our educational platform UROLUTS. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe the EAU Podcasts channel on your favorite podcast app. Until next time, keep learning and stay inspired.